quorum.
All right. This is Ben Steffen. Secretary Laura Herrera Scott is not able to attend today, so she's asked me to sit in. So we'll call the meeting to order, and we'll start with approval of the minutes. Is that right?
That is correct.
Okay. You have received the minutes and have read the minutes. Are there any changes to the minutes before we?
Ben, can I do a little housekeeping before you start?
Sure.
If you're not a board member, can you go off camera unless you're speaking? It helps us as we're trying to get votes. And board members, for your vote, please raise your hand and keep your hand up physically until Cynthia has acknowledged your vote. Okay. All right, Sherelle, if you can go off camera, that would be great.
Okay.
I'm trying to figure it out.
And yeah, who do we're missing someone. Aika, if you can come on camera.
So let's, as I mentioned, you have the Board of Trustees minutes from October 21st. I'll entertain a motion to approve the minutes.
So moved. I'll second.
Cynthia, did you get the person who made the motion and second?
Yes.
Okay, fine. All those in favor? Raise your hands.
I just need Aika. I have everybody else. Thank you.
Okay. Thank you.
We need
I
Aika.
don't have enough votes. I need Aika.
I put my hand up, but yes.
Okay, I can't see you. You're
We
not on
can't
camera.
see you.
Aika, do you approve the minutes?
Yes.
Okay, I think we have the sufficient votes. Okay, we'll now turn it over to, we don't have any public comments today. Is that correct, Cynthia?
That's correct.
All right, and do we have an executive director's report? Or excuse me, it's the committee reports are first, the Standing Advisory Committee, board member Aika, you have a short presentation.
I don't, but I will share that we are in the process of recruitment to add individuals to the Standing Advisory Committee. So I know some of you have seen the recruitment and have shared on your social media and extended those invitations for people to consider through your networks. So please continue to do that. And probably in an upcoming meeting, I'll have a more detailed description of where we are in the process.
Aika, or if I might just ask if Johanna or Amelia have anything to report from the 11/14 Standing Advisory Committee meeting? You're on mute.
Hearing no comments from staff, let's move to the Finance Committee. And as I understand it, board member Tanasia is not here today.
That is correct. Tony and or Scott, do you want to give a brief update on what was discussed at the November 24th meeting?
To look at it now. Be honest with you.
Go ahead, Tony.
Yeah, I have to look back and get the let me look at the agenda. I wouldn't expect to do this. Hang on.
Yeah, I'm in the same position, Tony, that if I'd known, I would have prepared something, but I'd have to look back at notes if you can do that. And what we're going to do is jump ahead to Michelle's executive director update, and then we'll come back to you, Tony.
Okay.
Well, thank you very much, Vice Chair Steffen. So we are just thrilled beyond measure that we finished our open enrollment on the 15th. We've had the best year ever in the history of the exchange. So we enrolled 247,243 Marylanders. That was up 16% from last year, but more important, that was up 56% since the pandemic. So we know that, during the pandemic, we were really able to demonstrate to consumers how important having health coverage is, and that's continued. Other really great reports are young adult enrollments, that's age 18 to 37, that grew 21% to 89,642. That makes up 36% of our total enrollment, which is wonderful because we know the younger, healthier people we have in the whole risk pool mix, the better it is for rates for everyone. Our communities that we focus on every year, our Black consumers grew 23%, our Hispanic consumers grew 25%. And really excited that this year we had 249 DACA enrollees enroll. Of course, we're hopeful that we can keep them enrolled throughout the rest of the year. Our new consumers were down 4%, which we are not surprised by. We anticipated that because of having the Medicaid unwind all year and where we were bringing people over from Medicaid. Renewals, however, were up 22%. And this says to us many things. One, it says that consumers like the health plans and the coverage they're getting. They're finding them affordable enough to continue to remain in them and not cancel their coverage. And that our systems, of course, we auto-renew. 99% of consumers get auto-renewed because our systems are able to do that. So really good information. Consumers that qualified for financial help, up 15%, and consumers who don't even need financial help, up 16%. So again, that tells us as a testament to our outreach efforts, to having a brand name that people know. Maryland Health Connection is a place to go in Maryland to get health coverage, that our producer community finds our services well and good, and we assist them greatly in being able to manage their enrollees as well. So thrilled about that. Dental plans, which we don't often talk about, always kind of the little silent surprise, up 23%, over 92,000 Marylanders have dental coverage through Maryland Health Connection. And again, we don't really promote this as much as we do our health coverage, but anyone can purchase a dental plan through Maryland Health Connection. So people who get employer-sponsored health coverage, but they don't offer dental coverage, we're finding that it's a good place to come to get dental coverage. And vision plans, something we newly added last year, tripled this year. That's still not a huge number, but we went from 200 to 850. And we know that VSP, the vision vendor, had last year really commented on how good of a job we did at getting consumers enrolled, and that those consumers stayed in their coverage. We all know, but I'll just reiterate that we had 5 insurance carriers participating this year, so we're thrilled about that. That's the most since 2017. And then to our other 2 initiatives, one that's coming into play right now, check the box when you file your taxes. If you don't have health insurance and you'd like to get health insurance, you check the box. We've had over 15,000 people get coverage by checking that box since 2020. Likewise, when individuals go get file for unemployment, if they've lost their employment, they can also check a box. And since 2022, we've had more than 25,000 people get health coverage through that avenue. So multiple ways to get coverage. We're here doing what we've set out to do, and we're thrilled about that. Moving into state updates, the governor releases budget. The exchange fared well in that process, so we're happy about that. Of course, now the legislature has their review and their ability to change the budget. One of the things that we are doing a lot of education with legislators in Maryland about is the reinsurance fund, because when you look at our exchange, we're just a tiny little, we have 73 state staff. We're a small little agency. But if you look at our budget, it looks like we have lots of money because of the pass-through for the reinsurance funding. So it becomes an interesting pot of funds, especially when we are in times like we're in now, where there's a real challenge to tap into that funding. We've been educating our legislators that any money that's taken out of that fund will make the reinsurance program less solvent and likely not be able to make it through to 2028. We know that we've been having to take more out as the federal funds decrease. Of course, we have no idea what will happen with federal fund pass-through in the next several years. So we really need to protect that as for our reinsurance program that we have in place. Also, just going on the legislature, we have the young adult subsidy bill that is making our two-year pilot, our two-year pilot program, so it was a total of 4 years, a permanent program tied to the reinsurance fund. So if there's no money in the reinsurance fund, there's no young adult subsidy program, but we have clearly demonstrated just the strength of that program and how good it's been for the whole pool. The other thing that's going on is we, under the change, again, not so much in this administration, the federal level, but CMS is doing a lot more scrutiny of our contracts and anything that gets federal funding. So you will start to see as a board, we staff have to put all of our contractual proposals, we have to send them to MDH. They send them first to CMS for approval, and then we'll bring them to the board. This is something relatively new for us. You'll see the ones today, when the board votes on them, they will be contingent upon federal or approval from the federal government for the federal funding. So another little layer that we're going to have to go through. And then just moving into federal, we are all, waiting to see what new executive orders or new legislation will come out. The good news is our 1332 waiver was approved. So we got that done before the change in the federal administration. Whether or not that will stick, we don't know. The 2026 final notice of benefit payment parameters was released. Big concern right now, as I've shared with all of you, is the expanded tax credits, which has just made it more affordable for so many Americans to get health coverage. We are doing an awful lot of education again with our state legislature and with our federal delegation, and really sharing information of how many people in their districts will be affected and lose coverage and what that would mean to their communities. So I will stop there. That's a lot for today, and I'm happy to take any questions.
Thank you, Michelle. First off, I want to congratulate the staff on all of the work over the past 3 months in engaging Maryland residents in the health benefit exchange. The Maryland Health Connection is one of the programs that we should all be proud of, and work continues to progress. I did wonder, in terms of, maybe it's early, but do you have a breakout or approximate breakout in the enrollment distribution among the 5 payers? Obviously, CareFirst and Kaiser would be, I suspect, dominant, but how did some of the newer carriers fare? Do you have that yet, Michelle?
We do have that yet, and I don't have it right in front of me, but United Healthcare has just continued to increase their enrollment. So I would say, and team, correct me if I'm wrong on this, United Healthcare, I think, had, was up at the top with CareFirst, then Kaiser, then Aetna, and then WellPoint, I think, is the newest carrier. So pretty much in that, but we are seeing what it was intended to do with multiple carriers is more of a mix. Things starting to level out a little bit with a few high players and the newer ones a little bit lower.
Thank you. Other questions for Michelle? Okay. Uh, Before we go on, I wanted to circle back to Tony to see if he had any update on the Finance Committee, which let the record show that I also attended, but I'm not prepared to talk about it. I have to go back to my notes, but if you can help us out, Tony, that'd be great.
Sure. Basically, there were 4 items on the agenda. The first item was to review the financial report through September. And we reviewed that, and the information that you received through November with the board information that you received is current and up to date. So basically that made September's financial not obsolete, but it's updated in November's. We also went over the IDIQ RFR process, keeping and highlighting some changes in process due to some recommendations made to us by OLA. The third thing is the compliance reporting. Scott reviewed the compliance report, and I don't believe we got around to privacy. I think we put that on hold, and maybe Scott can confirm that. But and that's pretty much all that I have.
Yeah, thank you, Tony. I'll just dovetail off of that. The compliance report was basically an update as of November 20th regarding the then state of the OLA audit, which at that time we were still waiting for the report. So it was a brief compliance presentation. And you're correct, Tony, we did not get around to the short privacy presentation.
Thank you, Scott. Questions for Tony or Scott? Hearing none. I also want to recognize that board member Rodriguez has joined us a bit ago, but I want to make sure everyone's aware that she's also here. Our next agenda item, we have some regulations to consider. Johanna, maybe and Marks will present. Johanna, the floor is yours. Johanna, we're not hearing you. Michelle, can you hear me?
I can hear you just fine. I think Johanna's trying, she might be having to dial in on her phone.
Okay. All right, let's give her a second.
Yeah. I think she's having some technical audio issues.
Hi, can you hear me now? My
Yes, we
apologies
can
for
hear
those
you.
difficulties. Okay, so sorry for that. Yeah, so we have a couple of regulations to bring to you today for final approval. So the first is a change for our special enrollment period for loss of Medicaid coverage. So we want to we're proposing to increase that special enrollment period from 90 days to 120 days. And we're proposing this so that we can line up with what's known as the reconsideration period under Medicaid. Medicaid expanded that period from 90 to 120 days during the public health emergency unwinding. And during that reconsideration period, an individual who was denied Medicaid can request reconsideration for enrollment. And if they get the determination that they're not ultimately not eligible to enroll in Medicaid, then of course they have the opportunity to enroll in QHP. So by aligning these periods, we give someone who gets that redetermination after the 90th day the opportunity still to get into a qualified health plan. In proposing this, we're following the lead of the federal government, which similarly has aligned their loss of Medicaid special enrollment period with reconsideration. So I think if we move on to the next slide, and just background here, we brought this to you as proposed in August. There's very minor edit to our regulatory text to achieve this. It's shown highlighted on the screen. Yeah, next slide. I think is a timeline. So that just shows by voting on this today, the regulations will ultimately be effective February 17th. We did have a public comment period for 30 days after the proposed regulations were published and received no comments. And I think that's it.
Okay, I'll stop here. Do we have a motion to consider these regulations before we start ask questions of Joanna?
So moved then. I move to approve the final regulations as presented.
Second. I will second the motion. So a couple questions for so there were no questions during the initial comment period. Was that because any concerns were resolved in the informal regulation development process, or it's just no questions ever on this particular item?
During our informal stakeholder engagement prior to bringing the proposed regulations to the board, we did get a couple of comments in support, and then we got one comment from, I believe it was Kaiser, expressing some concerns with the idea that it could be confusing to consumers to have different special enrollment period lengths for Medicaid as opposed to loss of other types of coverage. We corresponded with that commenter. I think it's sort of an agree to disagree type of situation, and didn't then get a reiteration of any concerns during the formal period.
Thank you, Johanna. Other questions from board members? All those in favor of approving the final regulations to modify the Medicaid special enrollment period as presented by Johanna, say aye. Raise your hand. All those opposed, raise your hand.
Hey, everybody, thank you.
And Laura Crandon has joined us.
I saw that. Thank you.
Welcome, Board Member Crandon. All right. We have another regulation to consider, Joanna?
Yes. Our next regulatory package is to align various parts of our regulations with federal regulations, and then there is one technical update that we just threw in here that's separate from any federal conformity items. So again, these were brought to the board as proposed. We had our formal public comment period, and now are bringing them to the board to finalize. And it's on a subsequent slide, but I'm pretty sure we also did not get comments on these during the comment period. But to dive into quickly what is in this package, one is to clarify the effective date for the change to our failure to file and reconcile policy, or FTR as we call it. This is the federal requirement whereby if someone does not file their federal taxes and reconcile their receipt of premium tax credit in that tax filing, and they fail to do that for 2 consecutive years, they then become ineligible for advanced premium tax credits. And that is going into effect this year for 2025. So this is really something we don't have a choice on. We're required to implement this policy under federal law, but just making the appropriate updates to our state regulations to align. The next item is also one where we are aligning our state regulations with required federal reg change, which is simplifying the effective dates for all special enrollment periods. So currently, some SEPs have your coverage becomes effective on different dates depending on at what point of the month you enroll. Going forward, the federal rule is that your coverage will become effective the first of the month following the month that you enroll. So if you enroll on January 1st or January 21st, your coverage will become effective on February 1st. So cleaning up our regulations to make that clear. The next item is related to our special enrollment period for individuals with incomes below 150% of the federal poverty level. The federal government established a year-round special enrollment opportunity for these lowest income enrollees in qualified health plans. These are often individuals who are transitioning off of Medicaid into a qualified health plan during the year. And normally, if you lose coverage, you have to enroll within 90 days of that loss of coverage. However, if you are in this lowest income group, the special enrollment period would allow you to enroll beyond those 90 days. Beyond that typical 90-day duration. In doing this, we're following the feds again who established this special enrollment opportunity. The feds initially tied eligibility for this SEP to have an expected
meeting right now. Can I talk?
Of 0% under federal guidelines, meaning you're eligible for enough premium tax credit to fully cover your premium. The feds removed that linkage in their regulations, essentially to acknowledge the fact that if the enhanced premium subsidies end at the end of this year, if those 2 items are still linked, this SEP would no longer be relevant because nobody will have a 0% expected contribution. So functionally, by delinking these, that allows this special enrollment period to continue even if the enhanced tax credits expire. The 4th bullet point here is to allow retroactive termination of your private plan if an enrollee signs up for Medicare and has a retroactive effective date. So they can retroactively end their private coverage to align with when their Medicare coverage started. And then the last item is just a technical update to our regs. In reviewing them, we realized that we had some repeated language related to the due date for your premium payment. It was just literally like somehow we had repeated some sections of regulation. So we are just cleaning that up so we don't have that redundancy. Next slide. So yes, if the board approves these today, they'll go into effect on the 17th. And next slide. Yep, and that's it.
Thank you, Johanna. First off, to get us started here, do I have a motion to consider changes to the MHBE's regulations to conform with the federal law?
I can make the motion to approve the final regulations as presented.
So do I have a second?
I'll second.
Thank you. Do you have any questions? I have one, but I'll let others go first. So, Johanna, you mentioned the Medicare A and B retroactive changes. Would beneficiaries be eligible for refunds from their private insurance coverage, or is it is just simply the retroactive changes? Is that all this does, or does it require a commercial payer to refund those premium payments to a beneficiary who didn't realize they had to enroll in Medicare?
Our regulations would not require that refund. I think there may be regulations generally under the MIA that would speak to that, but the MHBE would not directly address that. I think in the circumstance where this comes up, we would be doing this manually with individuals. It's not something they would be able to do through the system because there are considerations that we would want to discuss them, like, and with the enrollee and the carrier around premium, around if they had any claims, what would happen to their claims during that period. So I think it would be a very manual process with hand-holding by our team. This isn't something we see or expect to see regularly.
When a enrollee reaches 65, is there any communication to that individual that they should enroll in at least Medicare Part A?
Yes, in the last year or two, actually, we implemented automated outreach to individuals ahead of their 65th birthday to remind them to sign up for Medicare.
Yeah, thank you. Other questions? Okay, I think we can vote. So you've already heard the motion. All those in favor, say, raise your hand.
I don't see Laura Crandon, but I don't know.
Laura, do you want to turn on your camera?
She did have it on.
Okay.
Is that her hand up? Do you have your hand up, Laura? Okay.
All right.
And then, all right, we're good. Thank you.
The motion passes. So our next item is the proposed 2026 plan certification standards. We have a return engagement from Johanna. Go ahead.
Thank you. This is my finale appearance, I think, for today. So yes, happy to speak to our proposed 2026 plan certification standards. So as most of you know, we set plan certification standards for plans sold through Maryland Health Connection. And those standards encompass items such as plan design, operational standards, and other items that we wish to require from our carriers. And our value plan standards are one type of our plan certification standard. We initially implemented value plans in 2020, and under the requirement, which has evolved over the years, but this has been consistent since 2020, all carriers have to offer one value plan at each of the bronze, silver, and gold medal levels. In addition to that, in 2025, they can offer two plans of their own choosing, own design at each medal level. So we have the one value plan per medal level, and then the two plans that, if they want, they can offer in addition. Our goal with value plans is to promote affordability and access to coverage by doing things like using co-pays, which we know consumers prefer and find more understandable rather than co-insurance in the plan design, providing key services pre-deductible with just that co-pay so that someone doesn't have to meet their multi-$1,000 deductible in order to get coverage. It also simplifies plan choice because the value plans at each medal level have the same cost sharing and the same benefits. Consumers can compare them across carriers and shop based on premium, network, and quality are really the three items that they then have to consider. So it takes some of the complexity of that plan comparison away. And then additionally, one of our goals is to promote health equity and to align our plan designs with the larger goals of the state population health initiative. So one significant way we have done that is by making many standard diabetes care services available for free under the value plans to promote management of that condition. Next slide. So just to recap our process to get to presenting these to you today, we have a value plan stakeholder work group, which includes all of our key stakeholders. They developed and unanimously recommended draft designs over the summer, which we presented to the Standing Advisory Committee and then presented as draft to the board in September. Then in the fall, the Federal Actuarial Value, or AV calculator, was released. As a reminder, actuarial value is a measure of how generous a plan is. So on average, for example, a silver plan will cover 70% of a person's medical costs in a year, and the enrollee would cover the other 30%. So each metal level has an assigned actuarial value, and the AV calculator is a tool that carriers use to input their plan designs, and it spits out the generosity. So there's a standardized way of judging that. So when that AV calculator comes out, we put in our draft plan designs to test if they met the required AVs for 2026. As you know, unsurprisingly, this typically happens each year. Adjustments were needed to bring them within the AV range. So we worked with the MIA and our contracted actuaries to come up with some suggestions, reconvened the work group, proposed that, got feedback, again, got unanimous recommendation for updated designs, held an informal public comment period prior to the board meeting, did not get any feedback during that, and are now bringing these to you. Following this, we would have another public comment period and then, of course, bring you the final standards. And we'd like to do that in February. That does mean a somewhat abridged public comment period compared to our typical 30 days that we aim for, which we tried to address by having the kind of pre-proposed comment period earlier this year. But we would like to finalize these in February if possible, because carriers need to get their plan materials ready to submit to the MIA and MHBE. So that's the timeline and stakeholder engagement that we used to put these together. Next slide. And so that's kind of technical, but we really tried to distill this down. So the recommended changes for the 2026 plan designs, so changes from our 2025 this year designs to those for 2026, were to reduce the lab copay in the bronze plan and 2 versions of the silver plan. So another kind of technical element to remind you about. In the silver plan, there's what we call the base silver, which is available to people above 250% of the federal poverty level. And then for lower income individuals, there are silver plans that offer reduced cost sharing. And so those are referenced with the nomenclature silver and then the actuarial value of the plan after. So there's a silver 73, 87, and 94. So each of those silver plans is for lower income individuals and offers a higher actuarial value. So folks have lower out-of-pocket costs. So anyway, to return to the updates, reducing the lab copays basically where we could, and this was one of the main suggestions from the work group over the summer, that we've gotten feedback from brokers and navigators that labs are a particularly important service for many individuals, and if we could make any tweaks to the plan, they wanted to see us reduce the lab copays. So we did that across those plans. The next is to align pediatric dental coinsurance rates for Class 3 and 4 major services. We had differential coinsurance rates for those Class 3 and 4 services. What we learned subsequently is it kind of depends on the carrier. whether they make that distinction between class 3 and 4, and really generally in the market, that major services category in dental has the same cost sharing for services within that broader major services category. So that's more of a technical fix. So those were the two changes that were made in the summer with the work group and brought to the board in the fall when we previewed this for you. And then subsequently, when the AB calculator came out and we realized we had to make some additional changes to bring our plans in line with the AB calculator, we made these following tweaks. We increased the maximum out-of-pocket amount across all of the plans. The maximum out-of-pocket is the most that an insurer has to pay for that an enrollee has to pay for services in a year. So once you hit your max out-of-pocket, the carrier will then pay 100% of costs for covered benefits received from an in-network provider. That maximum out-of-pocket number that is capped by the federal government, they update that every year. It's indexed, so it increases somewhat every year. And that's an easy place to go to when you need to reduce the AB to bring yourself in line with the AB calculator. Only about 2 to 5% of enrollees hit that maximum out of pocket each year, which is why that's kind of a first go-to to look to for a lever to pull when you need to bring AB down. The next recommendation is to increase the specialist copay from $100 to $110 in the bronze and 2 of the silver plans. And we looked at different places that we could increase copays, but in general, the feedback we've gotten is to avoid increasing copays on generic drugs, on primary care, as those are services that people really use a lot of. And when you really need to bring AB down, you still have to look at a service that is used decently much by enrollees, because if it's something that not many people use and you increase the cost sharing for that, it won't really make a difference in your actuarial value. So specialist is where we ended up driving to for our next change. We also did a slight increase in lab copays from $5 to $10 just in one of our silver plans. I know this goes against the overall reduction in lab copays we were trying to achieve, but we weighed several different ways of changing the Silver 94 plan with the work group, and this was the most palatable one. And then the last item here is another pretty technical fix, which is to increase outpatient rehabilitation and habilitation services copays by $3 from $2 to $5. Again, in only our Silver 94 plan. The copays then will align with our physical, speech, and occupational therapy copays in that plan, which are $5. In all of our other plans, all of these services have the same copay. These services are kind of duplicative, often coded similarly, and have the same copays. So it was a bit of a typo that they got misaligned in the 94 plan for 2025. So we're just updating that again for 2026. So that is it for recapping the changes. And if we go on to the next slide, I think you'll see a snapshot of all of the services. So you can see on the left kind of a long list of all of the services, and each plan design is a column across the table, and you can see the cost sharing associated with that. And this should also has been in your plan, in your materials for the board meeting. The yellow highlighting indicates where one of the changes that I just recapped is being made. Next slide. I think this is a further, the second part of that table, showing that the changes I was just recapping. And the next slide will show a few other items, including, so no changes here, but this is the list of diabetes services that we are continuing to plan to cover with no cost sharing for individuals. And I think that is it on the value plan item. So I'm happy to pause here, Ben, for questions on that topic, or I can continue on to the other.
Thank you, Johanna. It probably would be helpful. What percentage of the enrolled exchange population purchases value plans? Do you have that?
Yes, we've got about 34% of our population in value plans, up a bit from 30% last year.
Thank you. A second question, those rehab and habilitative services, the copays seemed shockingly low, especially when I look at specialty physician copays, which I think are relative to some other insurance products pretty high. I was wondering, those are historic values, but what's the rationale for such a low copay on outpatient rehab and habilitative services?
Sure, and if you could rewind 3 slides, Cynthia. Yep, there we go. Oh no, forward one more. No, the other direction. Yeah, there we go. So the guidance that we got from our work group for habilitative and rehabilitative, not this year, but the prior year when we were putting this together, was the feedback we got from stakeholders was a desire to align physical therapy, occupational therapy, and speech therapy with the primary care cost sharing. So you'll see in all of our plan designs, PTSD, OT are generally the same copay as primary care. And habilitative and rehabilitative, as I mentioned, we are aligning with PTSD, OT because often HAB and rehab are PTSD, OT, and then there's a couple of service categories like cardiac or pulmonary habilitative services that might be also under the HAB rehab category, but my understanding is most HAB and rehab services are PTSD, OT.
Thank you, Johanna. Other questions from the board? Let's see. I don't see anyone's hands up, so I think you can go ahead.
Okay. And then the one other proposed 2026 new plan certification standard we have for the board to consider relates to cost sharing for outpatient office visits for mental health and substance use disorder. So what we are proposing is to require equivalent cost sharing for primary care and mental health, substance use disorder, or MHBE for short, office visits. So we're proposing that carriers would look at their primary care cost sharing and then use that cost sharing for MHBE office visits. We would encourage carriers to use copay structures for the MHBE office visits, but not require that. And this would be for all carrier plans, not just value plans. We would be asking them to align their MHBE office visit copays across their plans with what they're using for the primary care visit in that plan. We did discuss this with the Standing Advisory Committee in November. We aim to take all of our proposed plan certification standards to the SAC before bringing them to the board to get feedback and receive support from the committee for this proposal. I think the next slide goes a little bit more into the background on this one. So as you may know, federal and state parity laws generally require parity in financial requirements, e.g. cost sharing for mental health and physical health conditions or behavioral health and physical health. But it is possible under those parity laws for a plan still to have less favorable cost sharing for the MHBE office visits than for primary care, even though the office visit is sort of like, I might think of it as the equivalent of a primary care office visit under the technicalities of the law. They don't actually have to be aligned. The reason this is coming up now is that we got some question and confusion from our consumer assistance workers, our navigators during open enrollment this year, because 3 of our carriers currently do already follow this standard. They have kind of the linked cost sharing across these services, but 2 of them do not. And so navigators who are familiar with parity and familiar with some of the carriers on our market just assumed that they had to be the same, that primary care and MHBE outpatient had to be the same. And then when they saw a couple carriers where they weren't, they thought something was wrong. So nothing's technically legally wrong, but it was generating confusion. And so both to reduce that confusion in the future and to promote the accessibility of MHBE services, we're making this proposal. As I mentioned, of our 5 carriers, 3 currently already comply with this. We reached out to the other 2 to discuss this. One kind of immediately voluntarily agreed to make that change in 2026, and the other got back to us that they were evaluating their request and just didn't have time to make a commitment at that time. So we think this should be a relatively low impact to the market to make this requirement. And I think that's it on this one.
Thank you, Johanna. Before we take questions, I'll read the motion. I move to approve the proposed plan certification standards for plan year 2026 as presented. Do I have a motion?
So moved.
Marie, and a second?
Aika has her hand.
Cynthia, did you get that?
No, I didn't hear who that was.
Aika
Okay.
seconded.
Okay,
And Laura Crandon had to drop off.
right,
FYI.
I saw her message. Thank you.
Any questions before we vote? Hearing and seeing none. All those in favor of approving the proposed 2026 certification standards, raise your hand. All
I
those,
only have 4.
if you're, should I,
Maria, I'm missing Maria.
Maria,
I got everybody else. You can put your hands down. I'm just looking for Maria. I don't
Yeah,
see.
no, Maria's there. She's got it.
Yes, I raised
Oh,
my
I'm sorry, I
hand.
had to switch you up. Gotcha. Thank you.
No
thank you,
problem.
Commissioner Rodriguez. Okay. We're moving right along here, and the show now moves to the board's procurement policy revisions. Our Assistant Attorney General and Principal Counsel for the board, Sharon Merriweather, is going to present. Go ahead, Sharon.
Thank you, Chair Stefan. I've come to present the some small changes to the board's procurement policy. And these were requested by the staff, procurement staff, just basically to align the policy with procedures that are now going on in the state procurement process and the COMAR. So first, and you should see that your amended policy has been color coded. So I'll just go with that. There are several changes to change executive director to executive director or designee, or change executive director to procurement officer. And this is to align with our current process. The policy had the executive director doing many things that the procurement officer or procurement officer designee does. So those were those changes there throughout. And also those changes you see in blue are to modify some of the terminology and align with the COMAR. So on those, you'll see that the name for what we call a simplified procurement are now called a small procurement. That's what they are called in the rest of the state. So we have aligned with that. In addition, change some of the contract values or I'll say the values of the procurement for the small procurement to align with what's going on in the state. So small procurements are now categorized by in 3 different categories, which they have been before, but the numbers have changed. So category 1 is valued at $0 to $5,000. Category 2 is $5,001 to $15,000, and those are the same, but category 3 is $15,001 to up to $100,000. And I believe that original was $50,000. So that has been changed. And what that does is give the procurement officer more discretion to approve small procurements without the executive director. In addition, it allows the procurement officer to get quotes. And for the category 1, the up to $5,000, the purpose always and the hope always is to get at least 3 quotes. But as long as they contact 3 vendors for that solicitation, that would be considered competitive. And from a category 1 procurement, the contract, you only need a PO or an order, and you don't need a full out contract to contract for the category 1. And then in green, we have also aligned with the procurement process. And for the green, you'll see that it states that MHBE will post its solicitations on Emma or the Maryland Marketplace. And that changes from and that's a process that they're already doing, but it changes the policy from saying that it can either be a sealed envelope or electronically. It just specifies that any solicitations will be accepted through Emma. And I think that's all. Are there any questions about the changes?
So Sharon, I may have misunderstood you, but can the procurement officer on that person's own authority consummate a contract, or does it still require the executive director to sign off on that contract?
So I believe the category 1, the procurement officer can sign out, and that's up to $5,000. But after that, and I'm looking here just to make sure I'm speaking right, it's going to be a contract. So the executive director will have to sign off on that.
Thank you. Other questions from the board? You can go ahead, Sharon. I don't know if you have more. Is that?
Okay, I don't think we have a motion here, but we will need a motion from the board to approve the amended procurement policy.
So I'll offer the motion if I could get, I move to approve the board's procurement policy revisions as presented.
I'll
Motion.
second. Oh, sorry.
Maria was in the mix. I'm not sure who else was there. Someone else spoke up, just so we have a,
Maria Rodriguez.
okay, thank you, Marie. All those in favor, raise your hand. Opposed?
Okay, I have it. Thank you.
All right.
Thank you.
So we now have some procurement items to consider. The first is the fulfillment contract not to exceed amount, which is the proposal will be to increase it. Tracy Gamble and Tamara Gunter are going to present. Go ahead, Tracy and Tamara. Like Tony's in there.
Yes, it's Tony. Tamara, do you want to go over the fulfillment services, or you want me to just go?
No, I can go on. I can take care of it.
Okay,
Thank you so much.
thank you.
Hello, thank you for allowing me to present today. The board presentation on the fulfillment center contract. The vendor is the fulfillment center contract for Art Negative Graphics Incorporated. On April the 15th, 2024, the board had previously approved a not to exceed amount for FY25 in the amount of $5,878,500. Since this time, there has been some modifications by CMS on how Medicaid notices are sent. Medicaid notices were previously sent to consumers by the household level. Currently, due to the CMS changes, Medicaid notices are sent to each individual member associated with the case. Let me give you an example. Before, one letter would go out to one household. Now, if you have 7 members in your household, 7 notices go out, and then you have to pay postage 7 different times. The projected fulfillment costs for FY25 will exceed the current not to exceed amount by $4,566,675. The funding split is a mix of 66% federal and 34% state, and that is for printing. For the postage, the federal funding split is 44% federal and 56% state for the postage. I want to go over the stats. Next slide, please. I'm sorry. I want to go over the just to give you some actuals and projections. Right now, we're already almost over what the not to exceed amount is. Again, it's because of the new CMS changes. Just to give you some projections, here's our actuals that we're spent and what we're planning on spending. Right now, in a total of $10,445,175 is what we will probably need to make sure we have enough for this contract period. Due to these changes, MHBE is coming to the board to request the board increase the fiscal year 25 not to exceed amount for Art Negative by, again, $4,566,675 to not exceed, with a total of $10,445,175. Is there any questions on this?
So Tamara, the 24 actuals are 8.8 million. Did we do a change in the not to exceed last year too? Or was it just?
No, so we did one
Yes.
change not to exceed. I'm sorry, go ahead,
Right.
Tony.
No, I was going to say we did do a change last year. The original amount last year was about $6.8 million, and we did come back to the board for an additional $2 million. So yes, last year we did. I'm sorry, Tamara.
Yeah, and that was for the PHE. Unwinding, I'm sorry.
Other questions?
So
I have a
this
question. Oh, sorry, Maria. Go ahead, Maria. I'll get in.
this increases to a lot for that each member receives a letter?
Yes, yeah, so how it's now, again, before the PHE and during the PHE, there was a CMS mandate that came down, and it stated that notices can no longer be sent by household level. So now Maryland was one of the states who were sending it by the household level. CMS changed that. We had to send it by the member level. So again, an example, if you have 7 members in your household, you know, it's very cost efficient to send that one letter out and put everybody's name on it. Now we have to send one letter individual to each member a part of that case.
Okay.
And
Thank you.
Tamara, if I can also just add to this, that we had anticipated that the public health emergency would have ended earlier. We did a 12-month rollout of that, but there were a lot of cases that got moved, delayed, moved later. And in fact, we're still finishing up now in December and January and February. I think we still have about 15,000 cases each that we're doing some what we're calling reconciliation on. So the tail on this was much longer than we had originally anticipated.
Yeah, just to give you another example, to piggyback off of what Michelle said, for December, we had over 50,000 that we had to send out. So any other questions? I think Marie, you have your hand up.
Yeah, Marie has a question.
Yeah, maybe a comment and a question, because I think the comment is, this is not a bad thing in terms of, even though it's not as cost efficient, right? It's like, you're doing, sending out letters for individual household members who may have different income or eligibility situations, particularly for kids. Is that correct? So it's actually,
Yes.
Yeah.
Yes.
yeah. So that's my first question, but comment. I guess the second question is, just because this is such a substantial increase, I just wanted to hear a little bit about how that impacts the exchange's overall budget. So that looks like it's a 66% approximately federal share for that. Can you just say a little bit more about that and how it might impact the FY25 budget for you?
Sure. So what happened is we have revised our MOU with MDH now, and we did put that cost inside of the MOU. That is part of the board's memo that went out. You guys have a copy of the memo? Can you take me back to the memo, please, Cynthia?
So it's not on the slide deck, is it?
Okay.
That's in their packet, Tamara.
Okay.
So so we've had an MOU with MDH for many years to pay for Medicaid costs. And this year, when we sent the MOU over for this fiscal year, we increased the amount so that MDH will be paying more for the Medicaid notices than they had in the past.
Okay,
So
great.
in answer
So
your
it's a
question,
zero
Marie,
impact.
That's correct. I was gonna say, to
Yeah.
answer your question, it's not gonna impact our budget. We don't have to go back for any deficiency. We've accounted for it.
Okay, great. Thank you. Thanks.
Any other questions I can answer?
So I will make the motion to approve the fulfillment NTE increase as presented. Do I have a second?
Second, this is Kat.
Any questions? Hearing none, all in favor, raise your right hand. Not your left, right hand only.
Thank you. I have it.
You have that, Cynthia?
Yes, I do. Thank you.
Thank you.
Thank you so
all
much.
All those opposed?
And then I'm just going to remind everyone, this is the one contingent, this and the one after that. Again, we've had to submit these back up through CMS. We don't anticipate any problem, but again, contingent on approval from CMS on the federal funding.
I hope you're right.
Yeah, I hope so too.
The next presentation is from Sherelle and Venkat, and it's a Salesforce license procurement presentation. Sherelle and Venkat, proceed.
Good afternoon. Thank you, Mr. Seven. I'm joined by our procurement officer, Cheryl Green, and today we are requesting the board to approve our extension of our Salesforce license. I'll give a brief overview about this application and how we are using it currently, and I'll hand it over to our procurement officer to proceed further. As the board already may know, the Salesforce platform is one of the core platform for handling our customer calls. When a consumer calls our call center, and this is the application the exchange uses to record the ticket, track the ticket, take throughout the workflow of the ticket until the disposition, auditing, and reviewing the tickets as well. And over the years, we expanded our Salesforce platform beyond customer relationship management solution, which is the ticketing solution, to various other applications. I have listed some of them here. For instance, to manage our entire IDIQ, time management process for more than 150 consultants, and our procurement requisition applications. And also we have integrated Salesforce with our core HBX system as well. We have connected that with our producer applications for our carrier integrations as well. And also recently, we have expanded this further to connect our latest applications such as live chat. And also we built an appeals portal over the last couple of years. And during this open enrollment, we have implemented an AI agent that would receive consumer calls specifically for password reset requests and automatically perform the task. In fact, we are seeing almost close to 40% of consumer calls in this area is automatically handled by the AI agent. And this AI agent is also integrated with the Salesforce system to automatically create a ticket and follow through the ticket and provide information to the call center representatives as well. So as you can see, this is one of becoming a core platform for support, and we intend to continue to expand this system within our budget and within the needs of the exchange, and also to tightly integrate with our core applications. With that introduction, I will hand it over to Cheryl.
I'm going to, next slide, please. This is the license costs and comparisons over the last 2 years. Next slide, please. The funding for the software is listed below. We do have a slight increase, but procurement and the program felt that it was justifiable based on the services that we'll be using it for. Next slide, please. The procurement summary is here. This contract will be for 1 year. The procurement method was the Intergovernmental Cooperative Purchase Agreement Task Order. The approved seller is Curaçao. And here are the numbers from last year versus this year. Next slide, please. And procurement dates, we received the quote in November. The board approved the request today, hopefully. We issued a task order upon a board's approval, and the procurement process will be complete on the 31st. Ooh, that was a tongue twister. All right, next slide, please. At this time, MHBE requests the board to exercise the Intergovernmental Cooperative Purchasing Agreement first year, 1 year option. We do have 2 requesting, we have another option next year. Award contract to Curaçao Technology Corporation in the amount of $1,522,434.73 with a federal participation of $1,806,092. Sorry about that. And state participation of $517,627.81 to procure the Salesforce licenses for the period of March 2nd, 2025 to March 1, 2026. Is that someone hand going up?
Thank you. Do we have a, who would like to make the motion? I will so moved. Is there a second?
This is Kat, I'll second.
Thank you, Board Member Rogers. Okay, questions? Was there a hand up? I think there was a hand up before we got the motion in place. Anybody have a question? Okay, all those in favor of approving the purchasing agreement and the extension, say, raise their hand.
Okay, thank you.
Thank you.
All those opposed? Nice job.
Thank you, Ben. Happy New Year.
You have your contract subject to CMS approval. I want to add that. I think Michelle emphasized that, but we don't want that to be ignored.
No, we don't. Thank you so much.
Thank you, Mr.
Uh, Venkat has a lengthy presentation, not really. Venkat has a presentation on the 2025 IT roadmap. Again, kudos to the entire staff, but certainly the IT implementation at the Maryland Health Connection has gotten not only rave reviews here in the state, but nationally. And I'm confident that Venkat and his team are going to continue to keep the Maryland Health Connection in the forefront of IT development and implementation and service. So Venkat, please proceed.
Thank you, Mr. Stefan and members of the board for your continued support. Definitely, we are very confident to continue to deliver to our customers and stakeholders as expected. And this is to give a quick overview for the board about our technology. When we say MHBE IT, what do we mean by that at a very high level? I will go from left to right. From the top, so you can see what we call as web apps, which is our web applications, the consumer portal, worker portal, broker portal, marketing portal, presumptive eligibility portal. As we continue to expand, these all form the core HBX system, web-based application, our core technology using Java-based, enterprise Java-based technology. And next, you see the mobile apps. This is the mobile apps version of almost everything you see on the left. Ours is one of the handful of, if not 2 or 3 exchanges in the country that has the end-to-end application workflow built in the mobile application. In fact, our mobile apps, mobile devices traffic during this open enrollment exceeded 65% of overall consumer traffic in terms of looking for information or requesting for seeking coverage and other information. So this is a very important platform for us, and we use both iOS and Android. And we use a platform called React Native. That's the latest platform we build our technology to disseminate to these 2 platforms. So we reduced over the years a lot of redundancies in building this platform. And as I noted earlier, the CRM is Salesforce is a very critical application, which has supported more than 8 million consumer inquiries since 2017. And the newer additions for us are the enterprise automation. We use robotic process automation technology for a variety of process automations. One of the significant achievements here back is in verifying consumer documents for Medicaid eligibility in some certain circumstances, specifically when we need to verify consumer documents for income and recently for certain Social Security documents as well. And these are more than 100,000 documents in a year. What it means is this many consumers have the opportunity to get to their coverage very quickly. This happens within a few minutes, as opposed to workers sending the document to a worker queue, which historically we had seen anywhere between 2 to 7 days is the timeline for consumer document to be verified. So it's a significant process improvement as well as a cost-saving strategy for us in the long run. And the AI agent, as I noted a little bit earlier, is an application when a consumer calls the call center for specific requests such as password reset requests, which we predominantly see during open enrollment. The AI agent seamlessly handles almost 40% of the calls at this time. With our support from our business operations team, we would like to expand this for other consumer requests, such as consumers asking for the status of their application or consumers asking for a printout of their 1095s, for example. So those workflows can be automated, and a lot of efficiency can be built in through this automation, as well as cost saving can be realized as well. And the next, you can see AI bot integrated, our AI integrated bot. And the last year, we have enhanced our chatbot application to respond to consumer queries more reasonably. We use the large language model GPT-4 integrated with our bot to provide more meaningful responses to consumers, thereby helping our consumers with simple queries. In fact, as you can see, it's more than 6 million responses have been handled by this bot since inception a few years back, and more than 2.3 million consumers have used this so far. And we also have another application, as you know, the Live Agent Chat, which connects the consumer to a call center worker. And we also have Broker Connect portal application as well, which I haven't shown here, but that's another successful product as well. Overall, these technologies handled by our internal team, as the board knows, through our state staff of 19 and more than 150 consulting staff through the IDIQ contract procurement. Next slide, please. So this is a very quick high-level accomplishment on technology from the last year. As I noted earlier, we integrated chatbot with GenAI technology, address more than 500,000, actually 650,000 queries in 2024. We enhanced the document verification processes. And also we have integrated AI-powered help inside the consumer portal, where when a consumer comes and asks, they are stuck in a very complex screen, such as income screen, for example. Consumers now can ask simple questions directly in natural language, and the bot can understand and provide meaningful responses for consumers to continue with the workflow. And we are also expanding our mobile application for a variety of capabilities, including enabling certain functionalities for our brokers. And as I have noted here, it's been used for more than 1,000 brokers also. And in the last year, we have migrated 10 out of 11 HPX lower environments from MD Think to MHBE's AWS platform with a targeted potential cost savings of $750,000 per year. And also more than, in addition to that, streamlining our deployment operations as well. We're already beginning to see the cost savings starting with the last month's invoice, so we would continue to monitor this closely as well. And last but not the least, there are numerous policies that state and federal government requires, and we have implemented several of them on time. And our systems are ready for any potential policy changes that we may see in the coming year as well. Next slide, please. So for 2025 IT strategy, these are I would pretty much call as 4 pillars in some ways. Number one is the cybersecurity for us. Our systems are thankfully continuously being secured over the years. And I think with the advent of AI, just like how much more we see the benefits, the same amount of threats also are possible. So in this year, we would be infusing more AI-powered security monitoring throughout the exchange. And we also want to give more options for consumers to log into our systems. Potentially, we will integrate with login.gov or id.me and other login options for our consumers. And our focus this year is also going to be more in terms of security awareness, providing security awareness and training around AI and relevant technologies for our staff to use all these technologies, as well as to be cautious on certain security risks that we are seeing as these technologies emerge. And number two would be innovation. As I noted earlier, more enhancements of RPA, AI-powered bot, and AI-assisted tools we will be implementing. And obviously, we have a robust AI policy we have started with the policy, and we will be following strictly. And we will be closely watching the federal and state mandates on AI adoption as well. And we have a secure messaging channel, which we would like to expand this year to provide more support to our consumers, which is a channel which is currently being used by our consumers, at least 100 tickets every day. So we would like to expand more. And also we have a primitive kind of data analytics platform implemented last year. We are going to expand that platform to provide our key stakeholders in policy to do more independent analysis of our data and potentially assist in policy formulation and monitoring the effects of impacts of the policies as well. And last but not the least, I listed here is transforming the exchange core architecture, which is a very critical project. It's a little bit long-term, runs into a year and a half. However, adopting the microservices architecture is a fundamental sustenance for the exchange in the long run. We don't want to be left out with the legacy technology, even though enterprise Java with all the modern technologies are currently there. We don't want to be left out. We will be adopting this technology where multiple technologies can integrate and talk to each other dynamically across the exchange. We are working on the early stages of it, and the first phase of the release is going in a couple of months. I'll provide the board more update as we progress here. And system integrations are key for us. As Secretary noted in the previous presentation, the unified benefits integration with MDH, DHS systems is a key for this year. And we will also be expanding our real-time enrollment with carriers more this year. And as Johanna had presented earlier, the small biz platform implementation is also fundamental for our performance this year as well. And for last but not the least, is the operations is our bread and butter. We would like to continue to enhance our operations and make sure the system bugs are resolved timely, and we have a very seamless system for our consumers. And we are also implementing a disaster recovery platform sometime in the middle of this year, where we would be able to dynamically switch from MDThink platform to MHBE's platform if necessary, to give us business continuity options in the case of emergency, in case of any disasters. And again, last but not the least, our systems will be more agile and nimble, and so that if we see any complex policy changes this year from federal government or otherwise, we will be able to tackle them quickly as well. Next slide, please. So very high level on the 4 focus areas. As I noted, security and disaster recovery, and a lot of initiatives under consumer engagement, looking into the data and analyzing the data and personalizing the experience, and also to having a system with a lot of automation that can deliver and deploy solutions at scale. And last but not least, providing our consumers a unified experience across various channels. Since we expand our consumer experience across the channels, we would like to give the consumers a unified experience across channels. For example, a consumer logging in through our consumer portal online through web. Let's say log out and go through your mobile app. Consumers should be able to continue in the same way, providing the same and similar experience across multiple channels. This is our technology focus. Next slide, please. Very quickly, these are the 4 major streams of how we do deployment. Every month we have a deployment, and in between every week, and as needed across various functions, special projects, enhancements, M&O, maintenance and operations, and Salesforce. As you can see, it's pretty busy and pretty tight. And over the years, our technology of deployment improved, and still there are a lot of work to do for automated deployments. Is going to be a focus for this year, but we are pretty confident that we can achieve these kind of deployments, complex deployments easily. Next slide, please. To sum up at a high level for our calendar year 2025, the goal is to enhance access to our consumers, improve the user, empower the user with information so that they can get to what they want quickly and easily, and enhance cybersecurity and technology, build AI-assisted cybersecurity, as well as a robust microservices architecture for HPX, and be resilient with our operations, react to any policies rapidly, and build a disaster recovery capability for business continuity, as well as build an enhanced data analytics platform for our stakeholders to look into our data and perform analytics, and that would help our policy formulation. And last but not the least, we are really focused on looking into AI, adopting AI responsibly, ethically, and we are beginning to work on several areas where AI technology can be adopted responsibly. With that, I would stop my presentation. I know I went through in a fast pace. Please feel free to ask any questions.
Thank you, Venkat. So I had one question as others are thinking of their questions. You mentioned in the infrastructure, you've migrated 10 of 11 HBX lower environments from MD Think to MHBE's environment.
Yeah.
So what is left on MD Think? There's quite a bit still environment.
On the lower environments, Mr. Stefan, there is only one lower environment. It's called UAT environments, the user acceptance testing environment. That requires certain connectivity with carriers, connectivity with other agencies, connectivity with CMS. So that's one environment. We wanted to keep it until the end of the open enrollment for any emergency. So beginning immediately, we will start removing that environment the next few weeks. And besides these 11 environments, we have our staging environment in MD Think, and obviously the production environment is on MD Think. So I would say, other than the couple of emergency deployment path relevant environments, we would probably have two or three environments left at MD Think. Obviously, the most important one is the production environment.
And how much does the MHBE pay MD Think on an annualized basis, even with the reduction in the lower level environments? Do you have any idea?
Yeah, the total we are invoiced around $6 to $7 million, around $6.5 million of overall average cost for AWS for all the software and the professional support services. And after moving the lower environments, we anticipate some reduction in the AWS cost, as well as quite a bit of reduction in the professional support services, totaling around, our expectation is to reduce cost around $750,000 to $1 million a year, operating exactly the same thing. However, we will have additional benefits of integrating these platforms into our processes, which we are continuing to enhance as well.
Thank you, Venkat. Other questions? One final question, Venkat. You have a lot of objectives for 2025. What's the one or two areas that you would be most proud of if you can implement for 2025? Because you've got a lot of things. I'm trying to give the commission, the board members, a roadmap for holding you a bit accountable for into the future. But what do you think would be the biggest leaps forward?
I think, as the board knows, AI is a significant technology that we need to adopt because it's very rapidly evolving and the potential for AI is huge. We are already using AI for smaller applications, like I noted, AI agent and AI-powered bot, AI-powered help system. And as we expand this technology, if I had to pick only one, probably I would go around innovation, and that's where a lot of opportunity for efficiency and cost saving and building system resilience and all tie with that.
Thank you very much.
Ben, I had a quick question, or maybe to follow up on what you said, Venkat, and thank you for this presentation. But I know we talked about AI, and sort of in my world, and in the insurance regulation world, we're talking a lot about responsible governance for AI and sort of being cautious, and then also making sure that the folks I regulate, those insurance companies have appropriate governance and tests for the use cases that they are using for AI, and there's always a person at the end. So can you talk a little bit about what your vision for that, for the exchanges, as you're thinking about deploying AI in some pretty key functions that are really important?
Yeah, sure. That's a great question. That's a very, very real thing that's looking at us on our face actually right now. So when we talk about AI implementation, we look at in 3 phases, I would say. The phase 1, all these phases are connected with data. And the reason is the amount of data that we feed, the right data that we feed, the decision's going to be that. That's the one reason. But more importantly, we are talking about consumer data most of the time. So our approach is in the first phase that we have been doing in the last year, we have not touched the consumer data for anything. So for example, when a consumer asks a question in Flora, the chatbot, the data is not coming from the outside the internet world. The data comes from our knowledge base that we very carefully craft and supply to the bot. So that data is publicly available data also. So that is one. So initially we are targeting all our applications to go around that only. The second phase is where we may have to do aggregation of data. For example, we may have to provide the bot or the AI tool the information of summary data of our enrollment, summary data of our plans. That would, for example, be very useful for consumers when they do plan shopping, for example. We can give an option for consumer. Do you want to see what consumers in your similar profile selected what kind of a plans? And just like a shopping experience where we don't use the individual information, but still use the summary data. Again, this is we have to approach this very carefully. Obviously, we have to work with carriers and make sure that all the stakeholders are in alignment with this. The third one is a lot more personalized data, where we do look into consumer data and potentially make some decisions based on the data. That requires a lot more vetting, a lot more care in terms of decision making, in terms of ensuring bias doesn't exist, or we get into other ethical issues that may be prevalent in AI technology. So we are very careful in that, looking into it. Right now, we are only working on the phase 1, where we can use the commonly available information, which is crafted by us, the exchange, as a knowledge base for the AI, and then provide that as a response to consumer based on the knowledge base. That's where we are doing. And in terms of public facing AI technology, in terms of internal technology, for example, we would like to implement a chat-like interface, like a open ChatGPT-like interface for our staff, for all of our MHBE staff, where you can ask a question about any system requirements. For example, did this particular Medicaid enhancement go live last year, or anything around it? So the bot would go into your entire requirements document repository and then provide a response. This will be a very useful tool for our staff, technical and business staff, where we can quickly identify where we need to make the system changes, as well as what is the current policy on the system. So that's very internal, and we would keep it within our firewall. We'll be very tightly monitoring that as well. At this time, using AI beyond that, we will be very closely monitoring, but at least at this time, it is not in this year's plan for now. But we will be monitoring very closely as well.
And Ken, if I can just add, I think to the commissioner's question in terms of governance. So back in November of 2023, Venkat and I went down and met with Secretary Savage and Nishant Shah at Do It. And Nishant is like overseeing AI for the state. So the state has come up with guardrails around the use of AI. Venkat, over the last year and a half, I guess, was completing his doctorate, and he chose the subject of AI in government organizations. So he published his thesis on this. And then also internally, what we've done is under, Venkat and the leadership team have put together an AI governance policy. So we have a policy, as Venkat has said, right now, I call it, when I'm talking about the closed AI, because it's closed to our own environment, our own data. But we're putting the appropriate guardrails in place with what the state is doing and with what we're doing, and really at a leadership level of having oversight over that for how we progress down this AI path.
Great. Thank you so much. Thanks.
Other questions? Well, thank you, Venkat, again. It's an impressive bill of particulars that you're going to be embarking on over the next year. We really appreciate your leadership in this area and commitment to the state of Maryland, because with the skills you have, I'm sure there are people that occasionally or even more frequently come calling, and your support for the initiatives here are really appreciated and they're highly valued. So thank you.
Thank you, Mr. Chairman. Thanks for your kind words.
That concludes our meeting. I did have a question from Michelle, if you would indulge me.
Yes, please.
So last year we did pass the insurance coverage expansion, making it possible for residents without documentation to enroll. That will be in 2020, beginning in calendar year 2026. Given recent changes at the national level, I am concerned about any sort of information that would be gathered and obtainable by other entities. And I would encourage you to think about that as you're moving forward with implementation, because I think that's going to be a real concern. I'd also, as I want to first of all commend you and the staff for the work that's done this year, but also remind everyone that coverage on the uninsured rate is still stubbornly at 6%. The health benefit exchange can't be expected to solve this on our own, but you can be an important siren for the need to continue to keep focused on access to insurance coverage. And I'm really hopeful that the teams that exist at MHBE, particularly Johanna, will work to come up with proposals that would allow us to knock down the coverage uninsured rate even further as we move into the next several years.
Couldn't agree with you more. Although we do have to have our eyes wide open that there may be things coming down the pike that we can't control that are going to impact our ability to offer coverage or affordable coverage. So we are working as hard as we can, not only at the federal level, but at the state level. Unfortunately, we have a legislature that is very committed to protecting healthcare access and coverage for Marylanders. So we'll all be marching along this new path together and trying to preserve what we have. Yes,
the elimination of the additional federal subsidies are particularly worrisome for people over 400% of the federal poverty, which in Maryland is barely a living wage. So, so with that, I'll entertain a motion to adjourn.
So moved.
Do I have a second? That was Marie.
Second.
Thank you, Aika. Thank you all for your attention and work today. And the next meeting, will there be a February meeting?
There is a February meeting, and again, it will be on Tuesday because of the holiday, which is on that Monday, so the third Tuesday of the month, and we'll get reminders out. We will not have a meeting in March, And the February meeting will be virtual as well. So thank you all for your participation today.
Great job, staff. Everything went smoothly despite the clumsiness of the chair. Thank you very much.
Oh, chair was great.
Great job, Ben. Thank you all.
Bye.
Bye.
Bye.